So it's been a really fascinating time to be on the forefront of melanoma care. We have so many new tools in our tool bag to take care of these people and really provide a lot of hope when we used to not have any. We've taken 5-year survival for stage 4 melanoma from about 7% up to 50% and sometimes higher than that. So we're talking about tremendous strides in survival for stage 4 melanoma.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Welcome to another episode of The Cancering Show. I'm your host, Dr. Jennifer Young-Pierce, and today I'm thrilled to bring back Dr. Harrison Howard, a surgical oncologist with a special interest in skin cancer and in particular melanoma. Skin cancer is the most common cancer in the United States, and we're heading into summer. That means here on the Gulf Coast, we are going to be getting into all sorts of outdoor activities that put us at risk for skin cancer. So it's a good time to discuss the types of skin cancer and which ones are potentially life-threatening. Also, I can't wait to ask Dr. Howard about the game-changing treatments that are now available for melanoma. Let's jump right in. Dr. Howard, welcome back to this show.
Thank you for having me. Glad to be here.
So we have you back now to talk about, I should say, one of your specialties, but you focus on skin cancer. And we want you to kind of jump off by telling our listeners, is all skin cancer created equal? Because we tend to use it as this big catch-all phrase.
No, it is not created equal. And I appreciate you bringing this up because this is one of my soapboxes, particularly as it relates to melanoma, which is what I focus probably 70 to 80% of my practice on. And you're right. People hear skin cancer and they think, oh, you just cut it off. No big whoop. That is true 80 to 90% of the time. So the most common type of skin cancer in the world is basal cell carcinoma. And generally speaking, yeah, you cut it off. You find it early. You cut it off. That's all there is to it. It's like 99% cure rate just with removing it. Squamous cell carcinoma, second most common type of skin cancer, pretty similar. If you catch it early, you cut it off. That's all there is to it. Now, that's with a little bit of a caveat. Squamous cell carcinoma, they are starting to get a little more aggressive. Still a very, very, very small percentage of them. But based on the nature of my practice, I'm kind of the guy that's seeing these really bad ones. And there are some that are more than just what a dermatologist can do in the office. There's a lot of times major reconstructions we have to do. Sometimes squamous cell cancers can spread. They are a little bit more inclined to come back locally, meaning at the same place they're removed. But still, squamous cell carcinomas, for the most part, easily treated by removing them. Sometimes, a lot of times, people have a topical, what's referred to as like topical chemo, where patients will come in and be like, oh, yeah, I'm a dermatologist, gave me a cream, and it kind of burns it off. There's a lot of different ways you can treat them. But when you cross into melanoma, you are dealing with a completely different beast. Now, if you catch a melanoma early, go to the dermatologist, you find it early, yeah, 99% of the time, if you cut it off, that's all you have to do. But it doesn't take very long for melanomas to become a life-threatening problem. And so when we look at melanomas, the first thing I look at is how deep into the skin it goes. It's measured in millimeters. And once you get over about 1 millimeter in depth, those are cancers that can spread and they can kill you. And I see it regularly. And so, the problem becomes we cut it off. A lot of times it's more extensive operations, taking out lymph nodes in addition to removing the cancer. And people think, okay, whatever, I don't need to come back. Yes, you do, because you're at a point where these are cancers that can come back in the lymph nodes, in other organs. And a lot of my job is monitoring patients to make sure that's not happening. And a lot of times I'm asking them questions and poking around, and they don't really even understand what I'm looking for. And I try to explain it, but people think, oh, it's a skin cancer. He's just checking he's a doctor.
Skin.
He's just doing whatever he does. No, I'm not. Through the years of experience, I kind of have an idea of how melanoma is going to come back, where it can come back, which, by the way, is anywhere. And so it's really important if you're a melanoma patient to understand how it comes back, where it can come back, and make sure you're following up appropriately to make sure that if it does come back, you catch it early.
Well, I think that for me, the scariest thing about melanoma is you can't tell by looking at it how deeply invasive it is.
Yeah, and it's more than that. We've read a lot of textbooks in our career. Melanoma doesn't read the textbook. Exactly. Cancer doesn't read the textbook,
exactly.
Right? So what I mean by that is, in general, we know how cancers generally behave, but not always. And so it's funny to me because a lot of times patients will come to me with a new melanoma, and I'll get a note from the dermatologist, and they'll say, well, I biopsied it at the deepest part. And I think, well, what does that mean? You don't know where the deepest part is, neither do I.
Right.
And so, that's one part. You don't really know how deep it is always. The way you biopsy it matters from that standpoint. But beyond that, most people think melanoma, black mole, looks funny, looks weird, honey, go get that checked out, that sort of thing. But a lot of times melanoma is not black. It's pink. And it's there's something called an amelanotic melanoma, which maybe looks more like a basal cell carcinoma or just a little rough spot on your skin. And so it can present a lot of different ways. What I advise patients is if you see something that's funny, tell your dermatologist, and you can usually push them to biopsy something. And a lot of times if they're a melanoma patient of mine and they have something they don't like, I'm usually pretty quick to biopsy it. 99% of the time it's to put it to rest and they don't have to worry about it. But every once in a while you find something that you weren't expecting, and it can, it can change somebody's life.
Yeah. And we know for all three, once you've had one, risk of having another increases.
So what I was always taught and what I tell my patients is once you get that first melanoma, your risk just went up tenfold. So you're 10 times more likely to get another melanoma as you were before you had one. And I think it's very important to point out, we're not talking about the first melanoma coming back. We're talking about another mole coming up somewhere else on your body, completely unrelated to your first one. And I see that all the time. I have repeat customers. Most patients that come to me, they've had other skin cancers. It's really pretty common that, maybe I have a patient that I took a melanoma off a couple of years ago and they come back with either a pre-melanoma or a new early melanoma. And that really gets into the importance of melanoma patients need to follow up with their dermatologist the rest of their life.
Right.
And so the good news is, even though their risk goes up significantly, generally speaking, if you have a second one, it's caught early because everybody's worried, right? Like the patient's worried, their doctors are worried, people are paying attention. And when you're kind of plugged in, and that's certainly you understand that this is health maintenance, right? When you do the right things, more often than not, you're going to catch a health problem early. And when you catch it early, it gives you a lot more opportunity to take care of it.
I never really thought about that, but I do think that is kind of this great sense of relief because you do worry that the next one is going to be worse. Yep. And it's nice to hear that.
Yeah. No,
not
nothing's
always,
100%. Every once in a while, one will slip through the cracks, so to speak. But generally speaking, they're generally caught a little bit earlier.
Yeah. Now, we've talked a lot about catching things early, but tell us about some of the newer treatments for melanoma, kind of how they're on the horizon and how they change the conversations you're having with your patients.
It's a fascinating time for melanoma treatment. And I think you can really you can kind of divide it up into two things. It's what are we doing surgically for melanoma, and then what are we doing systemically. And so when I say that, I mean, as I'm talking to a patient, I would say, okay, this is the chemotherapy talk. Now, we don't use chemotherapy per se in melanoma because it doesn't work, but we have other medicines like similar to chemotherapy where you have an IV, the medicine drips in your arm that work really well. As a surgeon, of course, I'm going to start with surgery.
Of course.
And I think it's some really interesting conversations that we have as what I refer to as melanoma nerds like myself when I'm at meetings and talking to my colleagues around the country and around the world that do what I do. There is this movement towards de-escalation of surgery in melanoma. This really started, you can argue, with the development of sentinel lymph node biopsy. So as you know, but for the listeners, when somebody was diagnosed with a melanoma in the 80s, even early 90s, we would remove the melanoma. And let's say if it was on the arm, we would also take out all the what we call regional lymph nodes. So all the lymph nodes in the area where that melanoma would spread. And so if that's a melanoma on your arm, we'd take out all the lymph nodes in your armpit. It's called an axillary dissection. And 80% of the time, we wouldn't find any cancer. Yay, that's great. Hey, I've got great news. Your cancer hasn't spread. And the patient would come back and say, that's great. But what about the swelling in my arm that I have to live with the rest of my life? And so out of the morbidity or the side effects of these big surgeries for melanoma, we realized that there was a better way, and a procedure called sentinel lymph node biopsy was developed. It happened to be invented by one of my mentors, Dr. Don Morton, who trained me in my fellowship. And so he was talking to a patient, essentially having that exact conversation, and he thought, how could I find the one lymph node, the first lymph node where the cancer would spread? And it was that idea that essentially developed this procedure that is now, a cornerstone for staging cancer, meaning figuring
across
out
the board.
It started in melanoma.
Yeah.
It's used in breast cancer and many other cancers.
Mm-hmm.
I think some of the
We
GYN
use it
cancers
in
as
GYN
well.
cancer
But it all started
almost.
from melanoma. That's where it started. And so now when somebody shows up with a more advanced melanoma, we remove it. But instead of removing all of their lymph nodes, whether it's their neck or their armpit or their groin, we usually take one or two. And so that was kind of the first step in de-escalation of surgery. And what we found is it works. It's very reliable. It minimizes side effects and has been a game changer for melanoma as well as many other cancers.
And I would assume also sentinel lymph nodes more accurate. I know they are in GYN cancer, because imagine instead of looking at 20 lymph nodes at a cursory glance, you get to look at one lymph node, to the nth degree microscopically. You're more likely to find the cancer.
A great point, and this is something that I gloss over and I don't really get into a lot, but you're exactly right. If you're taking out 20 lymph nodes, the pathologist cuts them in half. I'm simplifying this, obviously. They cut them in half. They look at both sides, don't see cancer, move on to the next one. I got 20 to do it. When you do sentinel node biopsy, you're giving the pathologist a high-risk lymph node. And so instead of cutting it in half, they quarter it, then they bisect it again, and they create a lot more surface area of the lymph node to look at. Essentially they're going through it with a fine-tooth comb.
Yes.
Instead of just, quickly glancing at it. So it is a little more sensitive. Generally speaking, the sensitivity of sentinel node biopsy is 96%.
Pretty
When
cool.
I talk to med students, I say, if you got a 96% on a test, would you be happy? Yeah. And most kids are like, yeah, I'd be pretty happy with that. Yeah. Now, you miss a couple. Nothing's perfect.
Sure.
But it's a very reliable, very accurate way of figuring out if their melanoma has spread in more of a minimally invasive approach. Another thing that came from that, which changed it was about 2017, I believe, where we used to take out one lymph node. If that was positive, we'd go back and take out all the lymph nodes at that point. We realized that didn't really help either. And so now if we take out a lymph node and it's positive, we don't do more surgery. We've learned that really only creates more side effects. It doesn't make people live longer. So that was another step towards de-escalating surgery. We have a clinical trial open at the MCI right now. We've been very successful enrolling it. And now what we're trying to figure out for people with advanced melanoma, how much skin around it do we need to take? Mm-hmm. It's really important that you take what's called a wide margin of skin around a melanoma because the way melanoma spreads, it can actually start to develop what we call satellites. And that's exactly what it sounds like. You get these little tumors around the primary tumor that are not connected. And so we typically go very wide around the tumor to capture any of those that we can't see. Very quick. Typically, we would do 2 centimeters for an advanced melanoma all the way around it. So that gives us sometimes a 5 centimeter defect, which is bigger, racquetball size hole. And depending on where that is in your body, sometimes it's not a big deal, but sometimes it's a very big deal. It creates problems with reconstruction, plastic surgery, skin grafts. You're more likely to have wound healing problems, more likely to have nerve damage. And we're not certain that it actually decreases the chance of the melanoma coming back. So this trial that we have going on, it's active right now, called MELMART-2. We're trying to decide, hey, can we take a little bit of a smaller margin, decreased wound healing issues while still doing an adequate operation? And so as we transition from surgery to systemic therapies for melanoma, what we're learning now is the medicines we have often work so well, typically immunotherapy. We're seeing, depending on the concoction that patients get, they may get somewhere in the 20, 30, maybe 40% of patients treated. They have what we call a complete pathologic response, meaning all the cancer goes away just from the treatment. And so we don't know that unless we take it out. So a lot of times we still do surgery, but we won't maybe take out as much as we did before to try to take a little piece of it, look at it under the microscope, have some information to look at the tumor. And if everything's dead, then a lot of times we can say, well, maybe we don't need to take out these other things. Brings up other conversations. Maybe we don't need to give you any more treatment because we've killed everything. So it's been a really fascinating time to, be on the forefront of melanoma care. We have so many new tools in our tool bag to take care of these people and really provide a lot of hope when we used to not have any. We've taken 5-year survival for stage 4 melanoma from about 7% up to 50% and sometimes higher than that. So we're talking about tremendous strides in survival for stage 4 melanoma.
Yeah, no, I think, when we look for those miracles in cancer care, they're right in front of us. I think the story of metastatic melanoma is just fascinating. For those of you who are interested, we had one of those stories, episode 33, Helen Bender-Bailey. The episode is called Feeling So Alive. You need to check it out.
Yeah. And, that's one story. I have stories like that daily. I mean, I had 2 patients last week that essentially were in her same situation. We treated them with immunotherapy before surgery. We call that neoadjuvant therapy. I took them to surgery last week. And in 2 separate patients, when I took their tumors out, all the cancer was dead. And what we're learning as these studies progress and as we learn more, we know that when all the cancer's dead, when we take it out, these are people that were very likely to die from their cancer. Now, all of a sudden, we're flipping that, and they have like 95% overall survival, like crazy numbers that we're seeing and crazy. Now, it doesn't work for everybody.
Sure.
But in the people it does work for, I mean, this is miraculous stuff.
Absolutely. And all of this was from clinical trials. Mm-hmm. For our listeners, give us some background kind of on clinical trials in general for cancer patients and kind of how to learn more about them.
Yeah. Now you're getting my juices flowing. I love clinical trials. This is how we push forward. So clinical trials is partly how we find new treatments, but more importantly, how we apply them to patients. So, we have usually scientists in the laboratory, PhDs, MDs, MD PhDs, people that have ideas on and understand how the cancer cells survive and thrive. And, conversely, how can we kill them? How can we tap into their machinery to kill them? And so, and this is where new drugs become available. And there's a sequence of events when we develop new drugs. Yes, we test them in the laboratory, but eventually we got to test them on people, right? This is what it's all about. We're trying to take care of each other. And so, you generally start with people that really are at a point where there's nothing else. And so they've been through everything and the cancer is still progressing. And so you start these new drugs and you just see what levels are safe to give, what dose maybe we see some effect, but also doesn't cause major side effects in a patient. And once we kind of see a safe dose, then we start applying it to broader sections of the population to try to see, hey, we have kind of the old-fashioned way we take care of this disease. Now we've got this new drug, new tool, new surgery, new radiation, new, insert whatever you got. How does it compare to the old-fashioned way? That's the way I look at it. That's kind of the simplest form of a clinical trial.
Right. I was going to say, I always tell patients, it's not or placebo when we're talking about cancer and cancer care.
Yeah.
It really is the old way and the new way.
Correct.
The current standard of care and the next standard of care.
And so, that's the crazy thing with clinical trials. I mean, I think we're all so prideful and we believe in what we do. And, that's important to some extent. But sometimes what we think is going to work doesn't work.
Right.
That's science, right? It's you test your hypothesis. Sometimes you're right. Sometimes you're wrong. Sometimes you find something you didn't expect. And so, it's generally speaking, I tell folks, look, you're going to at least get the textbook treatment that you would get, or you're going to get this new treatment. It might be better. It might not. It might be the same. We don't know. But I always encourage patients that this is how we make progress. The way we've gotten to where we are now is through clinical trials. Okay.
Absolutely.
We're giving people hope because of what has happened in the past. Then I kind of flip that on patients. And I truly believe this. I never promise a patient that they're going to benefit from a clinical trial, but I do promise them that if they get involved, they're going to help somebody down the road. Right. Because in 10 years, there's going to be somebody else with your problem sitting in this chair. And I think patients get really excited to know, you know what, I can do something to kind of pay it forward. This is a crummy situation I'm in, but maybe I can do something to help doctors and patients learn and help people 5, 10, 15 years from now. And I think that's something that patients can really get behind. I think the last thing I want to say is if you're involved in a clinical trial, to me, like, you're a hero. And what I really don't like to hear is people say, am I a guinea pig? You're not a guinea pig. I mean, this is real life stuff. We are trying to push science and medicine forward, and this is the way we do it. And, you may benefit from it, you may not, but there's going to be good win, lose, or draw that comes from it because we're going to learn.
Right. And I think, as doctors who are in academic medicine and encouraging and enrolling patients to clinical trial, we are proposing it to you because we believe you have the opportunity to have help, and that it is potentially in your situation better than the standard of care for whatever reason that is. And so I'm always saying the same thing, that it is not just this, potential benefit to you, but really an opportunity to turn your cancer into something positive that create. And we talk about that in survivorship as well. Patients really having that opportunity to find the silver lining. Yeah.
Yep, for sure.
So we can't talk about skin cancer without talking about prevention. You're in the Sun Belt. Yep. It is the spring and soon to be the summer.
Bathing suit season.
Yes. So what do you tell your patients who've had a diagnosis of skin cancer?
So I think first and foremost, you can't undo the past, right? So, I remember right when I kind of started, I'd be talking to older patients and they'd say, well, I used to lather up with baby oil and iodine, and like my eyes would pop out of my head. I didn't even realize that iodine was a sunbathing tool in the, back whenever it was. But, we've all done things in the past. I know I've gotten sunburned, and, it is what it is. So, I think seeing a dermatologist once a year is super important, right? It's just a part of going to the doctor. It's like women getting their mammograms, getting their pap smears, men getting their prostate checked. I mean, seeing a dermatologist regularly is important. You go to your doctor and you get your cholesterol checked. It's just part of maintenance, healthcare. And so you can't undo the past, but what you can do is be proactive in the future. The easiest way is to wear sunscreen. Sunscreen is proven to decrease and block the UV rays that cause DNA damage that lead to skin cancer. I think if you go to Walmart or wherever and go to the sunscreen aisle, man, there's a lot to choose from, and it can be overwhelming.
I was going to ask, is there a difference from a medical standpoint between the kind of mineral sunscreens and the regular topicals?
There are, and I got to be frank, I am not a sunscreen expert from that standpoint, but generally the minerals are like a shield. They block it, whereas the non-mineral, more chemical sunblocks, I think from my understanding, they kind of absorb the UV rays so it doesn't get into your DNA. The most important thing is it blocks you from the UV rays that causes DNA damage. And I think you can really get into the weeds with sunscreens as far as which ones are better. And I think for dermatologists know a little bit better about it than I do. What I encourage my patients to do is find one that you're going to use. I'd rather you use one that maybe is not the best than to not use one at all. I encourage an SPF of at least 30. You really don't have to go above 50 though. So the level of protection from SPF flattens out after about 50. So the protection you get from 100 SPF, it really isn't different from 50 SPF. I think perhaps the most important thing in my mind is you got to reapply. You can't just put on your sunscreen in the morning and expect it to work throughout the day. It wears off, just like most things we have, right? I have a couple cups of coffee because my caffeine wears out after a couple hours in the morning. You got to do the same thing with your sunscreen, especially when you're outside. It's hot. You're sweating. Maybe you're in a pool or in the ocean or whatever, and that will cause the sunscreen to wear off. So, I encourage people at least every 2 to 3 hours, you got to reapply. I personally like to wear clothing, so long sleeves, hat, hood, sunglasses. So, obviously clothing will protect your skin. There's so much clothing.
Whole brand of SPF clothing these days.
Have you had talked about that on any of your podcasts?
We've mentioned it briefly. Yeah, I have a big sun hat I'm taking to the beach next week. Yeah. So
there are a lot of people out there, there are clothing companies that infuse SPF into the fabric. I don't understand how that works, but and particularly for ladies, like the idea of a long sleeve bathing suit for a lot of women, I think has historically been kind of weird. We're seeing it more and more, and I completely applaud it. And it's because people are aware, like, maybe just sitting out here under the sun all day isn't a good thing to do, and they're right. So, the SPF clothing is great, for an active lifestyle, which I think I'd like to think I have. I'm on the water fishing a lot or playing golf. I like hoodies. I like hats. I usually wear long sleeves. The fabrics these days are really lightweight and breathable. There's so many great companies out there making really great products to cover your skin and protect you from the sun because, where we live, we're outside and it's just part of the lifestyle. And, my belief is we don't put patients through this so that they have to turn into a vampire, right? I believe in living life and living it abundantly. So you got to just understand the risk. You got to make lifestyle modifications and you go from there.
Well, I couldn't think of a better place to end. I think just knowing that we're doing all of this so people can live their lives and have a great time outdoors and stay protected.
For sure.
Thanks so much for coming into the studio
Thanks
today.
for having me back.
I love talking to Dr. Howard today. It got me so excited for this summer and all the fun things we're going to do. I so appreciated the way he debunks the notion that all skin cancers are created equal and described the unpredictability of melanoma and the fact that we all need to be watching out for it. This is such good information. I wanted to emphasize to all of our listeners how very important it is to protect your skin from the harmful UV rays. Summer's right around the corner, so make sure you, number one, use your sunscreen all day, every day. Number two, wear protective clothing, including a hat. And number three, stay on top of those skin screenings. That's my doctor's advice for you today. So until next time, keep cancering and take care of yourself. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.